And this patient is 64 years old male and suffer from chest pain for 3 months. And the risk factor are hypertension for 10 years, diameters for 10 years. The injection fraction is 60%. This is the endography about on May 12th. And we can see from the endography imaging the severe stenosis at distal left main and proximal to middle of left anterior descending with severe calcification. Next.
Okay, Dr. Dong already introduced the baseline information of the patient, and we already know that for the patient is a triple vessel disease patient, and the RC also with mild to moderate lesion in the proximal portion. The QFR value is 0.84. So this time the target vessel should be the left coronary artery. And we can see that patient is RC dominant vessel. So the RC is very large and the circle is relatively small. And Dr. Dong already introduced the left coronary artery bifurcation with severe stenosis and with severe calcification. And as we know, the angiogram to detect the calcium is inferior to the CT angiography. So for this patient, we did the CT angiography and do 3D reconstruction. Let's see the 3D reconstruction of this patient's left coronary artery. We already use this intelligent visualization system for several times, show the audience how to use this system. And this is the left coronary artery of this patient. We can see the green one is the circ, and the light blue one is the LED, and the white one is the calcified plaque, and the brown one is the soft plaque. And we can see it's just at the left main bifurcation area, there is a large calcified plaque just at the left main bifurcation. But at the ostium of the circ, a little bit soft plaque and a little bit calcified plaque. Next. We can enlarge the picture, zoom in, we can more clearly see the distribution of the calcified lesion. And this time we delete the brown soft tissue. We can see clearly the distribution of the calcified lesion at the left main and the calcified lesion and a little bit protrude to the ostium of the circ. And after we delete the brown soft tissue, we can see in the proximal LED should be deep calcification, But when we go further distal to the LED, we can see there is a relatively large calcified plaque embrace the proximal LED. So in that place should be what we should be pay more attention to. Next. This is two picture. The left one with the soft tissue and the right one deleted the soft tissue. We can clearly see the distribution of the calcified lesion in the proximal LED, very clear. And in the ostium, deep calcification, but go a little bit further. So the calcified lesion embrace. So I guess the angle should be about 270 maybe to so closely embrace the proximal LED lumen. Next. Okay, this time we delete the light blue LED. We can see the distribution of the calcified plaque clearly. And here is still a small tips and tricks that I'm already show to the audience, because we can see the aorta of the abdominal aorta also with severe calcification, and
Yes.
the guiding was a little bit difficult to advance further, and there should be a calcified plaque. If we forceful to advance, even we rotate the guiding, still couldn't cross. And this time we use balloon assist tracking technique. Last time I already showed to the audience a workhorse wire and 2.0 balloon inflated at the tip of the guiding to mimic the CHD's guiding. And the guiding could be easily advanced. And we do coronary angiogram this time, and we can see the RC is no problem, and just like last time. And this time left coronary artery we use Jackin's left 4.07 French guiding. And we can see from the angio severe calcification in the bifurcation, and the circle is relatively small, and the ostium of the circle relative normal. Okay, this is the spider view of the circle with left mean should be about right angle, and we can see severe calcified lesion in the ostium of the LED. This is the RU cranial view, diffuse, very diffuse lesion. But the virtual standing technique already show us if we implant maybe 3 stents from the middle portion of the IDD to the left main, the residual FFR maybe 0.997. So should be good enough. So the virtual standing technique also give us more guidance how to implant the stent. And because we already know from the CT 3D reconstruction there is calcified lesion at the ostium of the distal left main. So the ostium of the circle is relatively normal. So we prefer to choose one stent strategy. So in order to better debugging the left main calcified lesion, and we choose active Rota technique.
I mean, this is a very interesting case because this is a typical left mean bifurcation with a very severe calcified case. And just like the demonstration by Dr. Li, that we checked that there is a very severe calcified plaque at the distal left mean and also at the trunk of the bifurcation. Here, I'm demonstrating this hybrid system of IVUS and OCT. Actually, this is a fantastic demonstration, I think, that for some very complex plaque structures like the calcified plaque and also the vulnerable plaque, sometimes that the OCT image and also the IVUS image can give some very haziness and hard to tell whether it's a calcified plaque or it's, for example, TIGFA or something. But with the help of this hybrid system, we can easily tell the details of these plaques. And from this run is from the proximal LAD to the left main trunk. At the mid part of LAD, we can see that the vessel diameter is relatively 2.5 to 2.6 millimeter. And on the right side is the IVUS image. We can see that in the comparison of these two images, we can see some very severe eccentric and also high plaque burden plaque. As the pullback comes to the proximal part of LAD, we can see some calcification, some superficial, some deep calcification in combination. And then we can see that IVUS image is of high sensitivity to the calcified plaque. On the image, we can see some high bright sparkles here. And also on the right side, we can tell the detailed information of the calcified plaque. There is a very sharp border of the black and calcified plaque. And also with pulling back, we can see that this calcified plaque is relatively deep, and also the thickness is relatively big. As a pulling back from the proximal part of LAD, we can see some calcified plaque with similar to the circumferential. And also on the right side, we can measure the angle of the calcified plaque. This is a multiple bifurcation case. If you pay more attention to the angiography of this case, you may notice that this is only isolate septal and also only one isolated big diagonal. So we can see that this septal and diagonal is of key importance to the
Andrew.
heart function and also the prognosis of the patients. So like Professor Lee introduced, the whole idea of this procedure is not just maintaining the expansion of the stent, but also maintaining all the big branches to make sure the prognosis of the patients. And also, why do we perform active rotablation on this patient? If you see closely, you may notice that there is a relatively big and eccentric calcification at the bifurcation site of the left main. If we are using the traditional balloon-based plaque modification strategies, there is a of high likely and the chance to cause severe dissections, which cause the intima or hematoma at the left main bifurcation site. However, with the help of the debulking techniques of rotablation, to use the rotablation to reduce the plaque burden and also the plaque volume at the trunk of the left main bifurcation is of great importance in this case, because we need to treat the distal LVD lesion first. If we use a balloon-based plaque modification strategies, there is a high likely and potential risk to cause the big dissection and plaque shift to the circumflex, which is not, friendly for the following procedures. So this is why we perform the active rotablation first. This is relatively, we can see that so far the fluid is good. And also we check the pullback with a hybrid OCT and IVUS system to check that there is no, severe dissections, and also the flow is good.
ACT.
And we can see that Professor Lee is choosing a different size of the IVL system for the proximal part and also the left main trunk to make the therapy of the deep 270 degrees of calcification. Someone may be, interested what situation and what kind of cases is suitable for the IVL system. There are several indications for the lithotripsy usage in the calcification. First one, I think that compares to the different plaque modification system, IVL is suitable for deep calcification and calcified nodules, especially like in this case, at the opposite side of the circumflex ostium, there is a very typical, 270 degrees superficial SIP calcification. And the second one is like in this case, relatively large vessels. We know that if the vessel diameter is over 3.5 millimeter, rotablation system without the beneficial of the wire bias, it is of less likely to perform debulking techniques for relatively big vessels. However, in this case, we can see we can use lithotripsy for left main bifurcations, so it's suitable for relatively large vessels. When talking about the mechanism of the IVL system, someone may, worry about the risk of potential dissections, hematoma, and myocardial infarctions caused by this huge balloon. So like I said, that there is a relatively very low incidence. It's like 0.4, percent of flow limiting dissections and other this advantage of the IVL system. Now we are checking again the IVUS from the LED to the left main to check the instant result of the IVL system. Actually, there is a question from the audience wondering, is there any additional complications or risks associated with the procedure, and how can we manage? Actually, if you pay more attention to the whole, idea and procedures, how Professor Lee demonstrated, we can see that in this case, there are several things. First, it's a multiple bifurcation case. We need to maintain the opening of the side branches and especially the circumflex. So why we are performing the active rotablation, which means that we are performing the rotablation first. You can see we didn't use the balloon and the cutting balloon or NSE balloon to perform the I mean,
Okay.
balloon first because we want to try our best to avoid any potential dissections and hematomas. I mean, in this case, because this is a multiple bifurcation case, we need to use relative some time and energy to treat the distal LVD and the
30
septal
NFE
bifurcation
balloon,
site.
please.
So active rotablation can reduce the risk of potential dissections and hematomas in this case, which gives us time and I mean, how to say, the energy to solve the distal, I mean, calcified lesion and also the bifurcation site. So I think that active rotablation as the first time in this case is a good choice. It can avoid some potential, I mean, complications. And also the other things is that there is some very severe superficial, I mean, eccentric calcification. So we know that the
Andrew,
biggest problem of
test the window, please.
superficial and also eccentric calcification is restriction to the stent
Window,
expansion.
please.
We know that the former OCT studies demonstrated without any intravascular imaging system, the stent expansion ratio is only around 60% or 70%, which is
NFE
relatively
balloon,
low.
30.
So
Okay.
we can see that with the help of all these imaging devices, we know the distribution and also the severity of the calcification. So we choose wisely which kind of, I mean, modification strategies to use. After the rotablation, we use the IVUS to detect some very deep and very thick and calcification, especially at the left main trunk and the proximal diagonal. So we are choosing the IVL as a second strategies to treat all these kind of big calcifications. You can imagine when we are using some, I mean, big balloons to do the sequential
So
balloon
we can see
dilation
both septal branch and
is
diagonal
maintained.
branches patterns here.
Yes.
So why we didn't use pre-dilation balloon to dilate? Because I think we already use the IVL system,
Yes.
the standard cross. Okay, and okay, just like okay, post dilation balloon, please.
The audience wonders the how to say the necessary and the importance of this wire in the septal. I think that this is of great importance for this patient because you can see that it is almost an isolated septal. There is I mean, one big and isolated septal because so keeping its patency is of great importance. Sometimes this size of septal, the loose of this size of septal can also, in fact, I mean, influence the heart function of the patient, and also, not to mention the angina after the procedure. So we continue with the topic that we just talked about. There are several potential risks to lose the side branches, big hematomas, and dissections. And also, I think in this case, the other risk is to transform one strategy to a two-stent strategy. If you are using an scoring balloon on a very big balloon to make the dilation at the bifurcation site of the left main trunk, there is a high likely to cause some plaque, I mean, distribution and to the circumflex ostium or some minor dissections to the ostium of the circ, which is relatively difficult for the following procedures. The combination usage of rotablation and lithotripsy has been reported in several manuscripts. However, we want to emphasize that it is not a recommendation to the routine use of combination of rota and lithotripsy. In this case, why we are using the rota and the lithotripsy at the same time, as I just explained, is to use the rotablation to make a guarantee for the transformation of the potential, I mean, devices, and also that we want to avoid any potential dissections and hematomas.